Welcome to the Eye of the Needle podcast, where we discuss healthcare innovation and explore how visionary entrepreneurs and change leaders are reshaping the future of our industry.
Hi, I'm Pam Arlotto, your host for the Eye of the Needle podcast. In our last episode, Joe Arlotto and I had an interesting conversation around return on investment analysis, where we've been with it and what the next generation of ROI is going to look like. A number of you reached out and said, could you give me a little more detail? So today I'm going to go through a framework to give you something to hang your hat on, a couple of examples and a case study so that you can see the difference in what we've historically done to measure and evaluate ROI and what we're going to do in the next generation of ROI and how that will be very, very different. So let me pull up my slides and we'll kind of jump right in. So as I mentioned, this is about the next generation of ROI. And what does that mean and how is that different? As I mentioned, we've had a couple of books, actually 5 books on this topic. The most recent 2 are second edition of Beyond Return on Investment, and that book really walks through what an enterprise would need to do around this topic and the things that are important to drive success. So how to do the calculations, how to get agreement, how to govern, how it fits into your governance process, fits into your budgeting process, some of the calculations that financial leaders want to see, as well as operational leaders and other stakeholders. Orchestrating Value came out in 2020 and really was about how do we move from a traditional bricks and mortar siloed environment to where we're using digital tools in the digital age to drive a new form of population health and value-based care. It was always my contention, as long as we're hanging value-based care on the infrastructure of the old world or 1.0, if you watched my very first episode, we're going to have a little bit more of a struggle. So in the digital age, we have new capabilities, competencies, and ways of working that will make and enable population health in a much bigger way. So that book really addresses that, as well as a care management platform that will be the kind of core of the tools and technologies we use to drive value-based care. So historically, most of the ROI work that we've done has been for an individual enterprise. And that could be whether it's a project, whether it's a new technology you're implementing, or even whether you're a vendor selling into an organization and you want to prove to them that they will get a benefit or return from investing in your technology. That's more of the history when we were all in our little silos and the center of the universe in health systems was the hospital, and everything was geared toward filling those beds and keeping heads in beds, as they say. In the future, as things go more virtual, shift more toward the home, we're going to see different types of environments. Networks are very important today, whether that be a clinically integrated network, an accountable care organization network, an HIE or health information exchange, or some other type of affiliates with your organization. So that network effect is really part of the next generation and the type of ROI we need to think about. And then we hear the word ecosystem quite frequently. We'll define this more here in a moment, but ecosystem really involves a multitude of players. And more we're finding that there's a convergence of roles in the ecosystem. So you might have payers who are delivering care, or health systems who have insurance plans, et cetera, et cetera. So we'll talk about the differences of return on investment and how network and ecosystem is the next generation, and it's going to be less about what's happening. Well, what's happening within an enterprise will still be important. It's not going to be as profound and driving everything like it has historically. So let's look at each level, the enterprise, network, and ecosystem, and talk about how we measure the value. Historically, enterprise, it was financial, it was return on investment. Was your initiative aligned to a strategic goal, such as growth, or new services, or new markets, or revenue sources? Were you trying to become more operationally efficient? Were you trying to improve your financial performance or your quality and safety? All of those are very enterprise centric. And so often, as part of a budget process, organizations would want to see the ROI. Vendors in their sales process would incorporate an ROI as part of, you spend this money, you're going to get this kind of return. Very transactional, if you will. Organizations did not always come back at the end of the project and examine it to say, did they get the ROI? And they didn't adapt it or refine it as they learn more across the life cycle of that initiative. It's still, as I mentioned in the last episode, how big was the change you were trying to take on? And with that change, what were you willing to invest to accomplish that change? Really, both of those questions were a key part of ROI in that world. In the network, you've got interconnected organizations that are separate. Often they are not part of the same corporate structure. They share data, they share care delivery across multiple sites. And then in the ecosystem, this is the broader collaboration among a great group, a great number of health and healthcare stakeholders. It could include payers, providers, public health, community-based organizations, et cetera. So we see a lot of players involved in the ecosystem world. And at each level, I mentioned in the enterprise world, ROI was the measure, very quantitative, often expressed as a percentage. And it really was measured in phrases like net present value, IRR, cost benefit, et cetera, et cetera. Often organizations would have a hurdle rate that they had to hit to be able to even get in the conversation regarding the investment. In the network world, we see outcomes measures as, if not more important sometimes than just the ROI. It really indicates the result of a change initiative, a specific clinical intervention, in terms of the performance improvements you anticipate. The classic, of course, is reducing readmissions. But unlike ROI, it may be not just financial. There could be a clinical, an operational, an experiential impact or result. Those are often measured, once again, in a variety of different dashboard scorecards that organizations are tracking today. And then finally, the ecosystem, much broader, many more players. And in this environment, we're not just looking at ROI and outcomes, we're looking at the overall impact. There's some long-term or systemic change that result from a change initiative or intervention. It's broader than the previous two. And rather than it being a transaction like number one, we implement this and therefore we get this return, this is more transformational and in many cases innovative. So in the world of innovation and transformation, we'll be seeing a lot more happen in the ecosystem world. This is where we look at new business models, new operating models, even new care delivery and care management models. So all of those are going to be what we think about when we look at the future and next generation ROI. So as we think about these, I wanted to point out the language we use. Everyone remembers the crossing the chasm effort in the late 90s. And we discussed our goal was the triple aim. In the recent years, we've begun to talk about the quadruple aim. The triple aim included patient experience, population health while reducing cost, but we've also layered in the care team experience. Recent conversations want to expand it to the quintuple aim, but what we're beginning to say and see is rather than just keep adding an aim every 5 to 10 years, we need to change the conversation. And one phrase that I'm seeing used quite frequently now is a systemic aim. And what it does is look beyond just the patient and provider centered goals to look at the entire holistic ecosystem and the sustainability of the healthcare system. The innovations we're seeking, how do we adapt our infrastructure? How do we collaborate across multiple partners to really drive something very new? So creating new value from this systemic aim, this holistic approach, this collaborative approach, as opposed to just continuing to add one more thing we're going to measure as we did in the triple, quad, and quin aim world. This future impact is not just for one stakeholder group. While we know the push to have whole person care and do more on behalf of a frictionless consumer experience, engaging patients and their families in their own care, activating them, not just doing it to them, but having them part of the care team. We're also wanting to do a lot more so that the care team is augmented and they're working at their top of license, and that their competencies are enhanced based on new tools that are available, new data that's available, and just taking the workforce to a whole different level than they have been historically. Not relying just on tradition, but looking at future potential. And then ultimately, other stakeholders that we've mentioned, whether it be community organizations. We recently did a project in a 15-county community that had over 200 community-based organizations that were all trying to coordinate with each other and the care delivery organization. So that's a lot of players that need to do things like drive prevention, enhance population health and chronic disease management, and then align the social drivers of health with the care delivery processes, adapt to disruptions, and then ultimately sustain those parts of the health system that are making the right type of impact. In the systemic impact world, as I mentioned, it recognizes ROI in improving health outcomes is not just about the patients and providers, but system-wide efficiency, resilience, and innovation. And there are going to be so many criteria and attributes that are part of having this systemic impact. And I really want to encourage a holistic, a broad strategic view versus transactional or tactical. And I'm not going to read all these, but you can just begin to see some of the components that need to be integrated, planned for, addressed as part of this systemic impact and systemic change. So I want to go through a brief case study to compare kind of what it might have looked like historically and what this future next generation might look like. And this is actually from an article called The Untapped Potential of Payer Care Management by McKinsey in 2021. And I think it's a great example of the old world versus this future next generation world. And we'll talk a little bit about how we've done things in the past to demonstrate a return, but also a little bit about how our hands were tied, given the dependence on labor in our workforce, given the dependence on old technologies, and not fully taking advantage of the tools that we have at our disposal today to basically reinvent the way work is done. So in this example, the goal was to reduce readmissions, I mean, our favorite. And McKinsey walked through an example of one of their payer clients. And what they were saying is, of all the potential ROI, that they were leaving about 90% of the value on the table, mainly because of the lack of engagement with the members and the way the payers were trying to engage their members, but also the way they were targeting them, working with them, etc. And in this particular example, they deployed this care management program with the goal of reducing readmissions. And interestingly, from our work, we have found that care management is one of the disciplines that payers have typically had strength in that maybe care delivery organizations haven't. ACOs obviously have to play a role in this world, but the traditional payer, the way they managed care, was very much focused on reducing cost. That was their incentive. But in this scenario, they identified 20% of their members that they wanted to deploy this readmission reduction program to. 80% of members with likely unplanned admissions were not targeted in this process. So you can see the black dots. Those were the target members that they wanted to work with. They only got to about 15%. A quarter of them, they never even reached. They were doing outreach phone calls, and either they didn't have the right number, the person never picked up the phone, they left a message, they didn't get a call back, all of the above. Of those that they reached, they only actually engaged about 8%. And ultimately, of those, only 6% actually changed their behavior. So they never truly, back to leaving, all those gray dots are what was left on the table of the potential ROI of this initiative. So just seeing how difficult, and there are a lot of reasons. It's very manual, very labor intensive. There's no incentive for the member to really engage, or they just refuse to engage. And then once they're part of the program, are they really going to change what they do? Or is there an action on that member's part? And if we look broadly, it's kind of well recognized that care management has a huge impact, or has the potential to have huge impact in so many ways. Preventing specific medical events through early detection and diagnosis, making sure the individual patient is going to the right site. So do they need to go to an ER, or can they do it at a practice or freestanding urgent care facility? Can a home-based visit work? Can a virtual visit work? They're able to make sure the appropriate diagnosis, treatment, and management occurs. So are they getting the right intervention? Are they reducing or avoiding unnecessary procedures or diagnostics? Or how are they complying with their medication use? Are they able to close care gaps and make sure they're accurately coding for reimbursement purposes, and on and on and on? So there's many, many ways that care management has the potential to drive value, to drive ROI, to drive outcomes. And interestingly enough, this is still within a payer world or a payer enterprise. you start to layer in collaborative care management with care delivery organizations, with community-based organizations, you can begin to see the number of sources of value expand exponentially. So in this particular scenario, we're just right now still focused on the payer. But if we think about next generation actions, not just measurements, but actions that the payers could consider to potentially improve the ROI of care management, let's look at 4 that McKinsey highlighted in their article, and then let's talk about potentially other parts of the ecosystem if we really want to begin to look at impact. So targeting multiple high potential sources of value. So going back to that previous diagram, looking at trying to do multiple of those things, not just implement a readmission reduction program, but look, are there other things we could do as part of that outreach or as part of that engagement with the patients and their families? Can we engage them in a new and different way, not just some type of phone call, but let's use analytics and begin to break down the different types of consumers and patients and their needs. Can we contact them through multiple channels and leverage multiple channels and think about their incentives for engaging with us and what would make them want to engage? Look at what's driving them in their healthcare journey. And then right-size care management to where that patient is at that point in time. So make sure they're beginning to do things such as reducing clinically inappropriate spend, or help do it from the perspective of that consumer. What are they most interested in, and at what point in their journey, they're in healthcare inflection points, would they be most open to engagement? And then run care management with an operational mindset versus just a payment mindset. Look at how you engage other members of the care team. And this is where I was just going, is can you do things with the practice to get them to bring the conversation forward? Can you look at, particularly in some of the populations, underserved populations with access issues, can you get community health workers involved? Can we automate and digitize the process across the continuum, both in the care delivery continuum, but also the community service continuum? So that's how we begin to look at not just what a payer can do, but how the entire ecosystem can drive ROI outcomes and ultimately impact. So in this specific example, they were able, and this once again was just the payer world, but they were able to look at a 2-to-1 ROI for care management based on really customizing it for high risk populations, rising risk, and what was really important in the conditions that those different groups, as well as were experiencing. And you can see the impact, the percent of the population, but also the percent of the spend. And what they really did was design different types of care management. So everything from for healthy low risk populations to using virtual or digital engagement only, all the way through asynchronous light touch, some coaching, to managing specific conditions such as diabetes or other issues, and then being more and more complex where we intersperse both in-person and digital engagement. So while this is a very quick run through, you see this is different from just a single intervention that's not going to touch that much of a population, and driving ROI, driving impact, where you purposefully look at all of the factors, all of the potential impact areas or outcome areas, and then design a new and different program for that. So I want to summarize what we've talked about, and I want to talk about how do we measure each and what are we focused on. ROI It's very short term. It's usually going to happen often within about 12 months or a couple of 2 to 3 years at the most. We're looking at things like cost savings, revenue growth, et cetera, those operational factors or strategic factors, very transactional. And we use financial models. Absolutely. An example would be a hospital invests $500,000 in an AI-driven scheduling software, and they're able to save about $1 million by reducing unused OR time. Very cause and effect, very singular, if you will. The next example is back to that kind of more in that network space, and that's around the outcomes that multiple groups are able to work together, usually a little bit longer term, 2 to 5 years, and they're working on all of those quality measures, those process measures, all of the things that we've all been focusing on with both value-based purchasing and value-based care in recent years, but also some operational things like staff efficiency, workforce, et cetera. Every organization has a gazillion dashboards and scorecards and metrics. Usually these are static. In the future, these are going to be a lot more continuous and predictive, not just reporting what happened, but starting to say, what can we do? And then, but it's factors such as, are we reducing errors? Are we improving wait times, et cetera, et cetera? So in an example, in this situation, a health system implements RPM, or remote patient monitoring, and they're able to reduce readmissions by 20% and increase patient adherence to medication by 30%. Those definitely are viewed as positive outcomes, but not always. And you could probably also do some financial measures around those, but those are outcome measures. And the key difference here, outcomes are not always tied directly to financial returns, but they are critical in demonstrating performance improvement. And often you begin to have multi-stakeholders. In both of historically, this was happening within an enterprise, both of these. But as we move more and more and more toward that network environment, you'll see a lot more measures around outcomes for the network. And then finally, impact, this long-term change. It's going to be, 5+ years. We're going to see trends in population health, systemic policy shifts because of these changes. You'll see a lot of research, longitudinal studies, both quantitative and qualitative analyses. And then you'll begin to look at community-wide health improvement data. We're beginning to see a number of the health information exchanges expand and become community information exchanges, where they're looking at both the social drivers, social determinants, as well as the care delivery metrics. But we're going to see goals like reducing the chronic disease prevalence in a community, lowering spending for Medicaid populations, not just to cut the cost, but because we are doing more prevention and more wellness in those populations and teaching them more health literacy. And then beginning to see, as we all know, CMS has a goal that by 2030, that 100% Medicare patients will be on some type of value-based care. Right now, it's about half and half. And in the future, this next generation ROI, if you will, is going to be focused more longitudinally on impact and the systemic change that it's going to require qualitative, quantitative, and a number of mixed method evaluations, because we're going to have so many stakeholders that are participating in driving the change. So I hope this is helpful for those of you who reached out. And our next episode will be coming up in the next few weeks, where we hope to have a few more guests and have a conversation with those of you who are innovating and driving change. Thanks so much.